Good afternoon, everyone. First of all, I'd like to thank Dr. Pandey sir, Dr. Kumar sir, and Dr. Vijay for providing me this opportunity. This data is coming from a rural cancer center in which the patients have been treated from 2008 to 2014 with standard curative surgery, followed by standard adjuvant therapy, followed by with or without maintenance in stage 3 and stage 4A head neck oral cancers. So let me tell you something about this hospital. This is situated somewhere between Bombay and Goa in Ratnagiri. It deals with predominantly a population which has an agrarian or agriculture based economy. 40% of the people living there live in a below poverty line. Majority of the patients treated in this hospital are either through government sponsored schemes or through the trust fund managed by this hospital. And we are aware oral cancer is the most common cancer, especially among rural India, because of high prevalence of oral forms of tobacco use. And there has been a paucity of data for outcomes in oral cavity cancer, especially coming from a rural background. The aim of this study was to evaluate outcomes of all patients who have presented with operable oral cavity cancer. Objective is to evaluate the disease-free survival, the overall survival, and factors affecting outcome in this subset of patients. Coming on to material and methods. So all patients registered from 2008 to 2014 having upfront oral cavity but operable cancers were taken in this study. So only those patients who had presented with operable oral cavity cancer and subsequent underwent upfront definitive surgery were included for analysis. So the basic scheme of this study is all patients were presented with operable oral cavity cancers and upfront resected. Total number to begin is 335. Depending upon post-op histopathology report, patients received, as per standard indications, adjuvant radiotherapy, which is about 60 gray in 30 fractions, with or without concurrent weekly cisplatin, 30 milligram per meter square, to 5 to 6 weeks. So out of these 335, about 225 were the one which had a stage 3 and stage 4A or advanced oral cavity cancers. Depending upon the referral preferences prevalent during the 5-year treatment schedule between surgical and radiation oncology colleagues, 130 of them were referred for oral maintenance metronomic therapy, which was prescribed for a maximum duration of 18 months. The drug is methotrexate once a week, 15 milligram per meter square, and celecoxib 200 BD. The 95% patients were just observed every 3 monthly without receiving any maintenance therapy. We collected a baseline demographic profile, stage, tobacco consumption pattern, adjuvant therapy scheduling, and the pattern of failure. We did Kaplan-Meier analysis for DFS and overall survival, and log rank was used to evaluate any factors affecting outcome. So there has been some demographic variability in rural population compared to urban population. If you see, the median age is 54. In a couple of urban population studies, the median age in cities has been mentioned about 47. So it's slightly older in women, slightly older in rural population, 54. If you see the male is to female ratio in the study presented just before me and couple of other studies, the ratio is tilted more towards male, 3:1 or 4:1. In this spot, 1.7:1 male to female. Maybe the reason behind is because a lot of women in rural background has a habit of using oral form of tobacco, which is locally called as a masheri. And because of young male population and middle-aged males migrating to urban centers for more better opportunities, maybe that's the ratio of this one. Buccal mucosa in 53% is the most common subsite of oral cavity cancer. This also could be because of the habit of using or placing tobacco quid in the GB sulcus, which leads to chronic irritation. 55% of them had stage 4A. If you add the stage 3, about 68% of them total had advanced cancer to begin or to present with. The median follow-up of this study is 24 months. So as I just told, 225 or 67 patients had advanced operable cancer, with majority were of stage 4A. Buccal mucosa, the most common subside. This is quite interesting. 92% of the patients were addicted to smokeless tobacco, which in urban population has been reported to about 70%. 27% were smokers, which in urban population is around 40%. Coming on to overall entire cohort of patients, 335, overall median DFS and overall survival are 13 and 30 months with a 2-year DFS of 32 and OS of 54% respectively. So if you see the compliance of the patients, 95% of patients who were prescribed adjuvant radiation therapy started, of which 87 completed the complete course of radiation therapy, which is 60 gray and 30 fractions. Cisplatin was used in about 50% of the patients with a median number of cycles of about 4, the range from between 2 to 6. Pattern of local failure, local relapse was the most common, 65%, followed by metastasis, second most common, and regional and loco-regional failure in 11 and 5% respectively. Coming on to overall, so patient who had progressed did very poorly as compared to patients who didn't progress. This we all know about it. This has been consequently proven, and it is statistically significant. So coming on to the metronomic part of the data, about 130 of 225 patients, which is about 58%, did receive metronomic maintenance with a median of about 14 months. With a range of 3 to 18 months, and we found out that use of maintenance metronomic chemotherapy did improve the DFS. P-value is 0.22, 14 versus 8 months, and the overall survival was statistically significant with a difference of more than a year between them, 26 versus 14 months. These are the graphs which is showing the DFS on the left hand, which does crosses after about 50 months. And which is, though it shows a positive trend but not significant, but OS has come as a significant in this analysis, with the two curves clearly showing quite apart. In the subset analysis, age, sex and comorbidities didn't have any significant impact. So stage 1 is much better than stage 4, this we all know about, and metronomic adjuvant was the only one factor which did impact the overall survival in a locally advanced stage 3, stage 4A disease. So I'd like to conclude, oral cavity is definitely one of the major healthcare problems, especially in India and more of in rural India. And because of high prevalence of oral tobacco smokeless preparation use, majority of them are diagnosed with a stage 3, stage 4A. And we know the common pattern of failure is local, regional. Maybe maintenance metronomic therapy may delay or avoid recurrences in such subset of patients. And it needs to be evaluated prospectively. Now Tata Hospital has already planned metronomic chemotherapy in this cohort of patients. Maybe in 2-3 years we may get the answer to this question. So the conclusion is, as the time passes, we mature and progress. So since a couple of 2 or 3 years back, people were not very conversant with this, but with the recent introduction of several studies, retrospective and prospective, we are learning more and more about metronomic therapy. And this is the same hospital which I just showed you the initial picture. In last 2 years, it has converted into full-fledged medical college and has already started the MBBS functioning over there. So I think that will be all. Thank you very much.